am Tina Chai, a current pediatrics resident at Johns Hopkins, and I presented my work at the American Heart Association Scientific Sessions Conference. This work was largely conducted when I was a medical student at Vanderbilt University, with subsequent analyses completed during my residency at Hopkins. The project is titled Survivors of Childhood Cancers Exposed to Cardiotoxic Therapies Demonstrate Diastolic Dysfunction by Cardiac MRI. So a little bit of background. Cardiotoxicity from cancer therapy is a leading cause of morbidity and mortality in childhood cancer survivors. Studies have shown that leading causes of late mortality among childhood cancer survivors include cardiac death due to treatment-related causes, where cardiac radiation exposure and high dose of anthracycline exposure can increase the risk of late cardiac death. For this reason, children who receive anthracycline and/or chest radiation during their cancer treatment process are routinely monitored afterwards for symptoms of cardiac illness. A method to evaluate for cardiac dysfunction is through measurements on cardiac magnetic resonance imaging, or cardiac MRI. However, research on the cardiotoxic effects of cancer therapy has more so focused on systolic dysfunction seen through cardiac MRI. Less data are available on the effects of cancer treatments on diastolic parameters, especially diastolic cardiac MRI measurements. So the objective of this study was to evaluate whether childhood cancer survivors exhibit changes in diastolic function on cardiac MRI. And we thought, in our hypothesis, that childhood cancer patients would have worse cardiac MRI markers of diastolic function as compared to healthy pediatric patients. So this was a single-center retrospective analysis comparing two cohorts. The first was a childhood cancer survivors group who underwent cardiac MRI as a part of their cardio-oncology follow-up. And this group was compared to our second cohort, which was a previously collected cohort of healthy controls. And we found that childhood cancer survivors had a lower left ventricular ejection fraction, as well as a smaller left ventricular end diastolic volume normalized to body surface area. We also found that childhood cancer survivors had a slower peak ejection rate, peak filling rate, time to peak ejection rate, as well as a decrease in other markers of diastolic function that were all found to be statistically significant. So we concluded that childhood cancer survivors have worse filling and ejection when compared to healthy controls, even when correcting for demographics and known risk factors such as age, BMI, systolic blood pressure, and left ventricular ejection fraction. So our final conclusion of the study was that we hope markers of diastolic dysfunction, such as peak filling rate and peak ejection rate, can serve as early markers of cardiotoxicity in childhood cancer survivors. I would like to thank my mentors, Dr. Jonathan Soslow and Dr. David Burrell, and I would also like to thank the Pediatrics Residency Program for providing support to allow me to attend the American Heart Association Conference.